May I invite on stage chairpersons, Dr. G. Swanlata and Dr. Tukaram Jamale. I am honored to invite the speaker, Dr. George T. John.
BK virus, must be some fancy name, isn't it? Why BK virus? These belong to a group of a family of viruses. You can see what is in that complex bracket. BK polyoma virus, JC. You know what JC stands for? John Cunningham virus. And Merkel cell polyoma virus. Do you know what it causes? Merkel cell? It causes terrible malignancies, usually cutaneous with metastasis. Usually people die in about 6 months' time. I've had about 4 or 5 die on me in the last few years. So BK is a relatively innocuous, you think. Is BK associated with malignancy? BK is associated not just with urothelial malignancy. The genome has been found even in brain tumors in bone marrow transplant patients. So these viruses are relatively innocuous, but causes enough damage to the renal allograft. And our concern is basically that at the moment. This is the very first paper that reported it. It came from St. Mary's, London, and the first author, Dr. Gardner, the very famous virologist during that time. And she found and characterized a new papovirus, which was unlike any other virus that people knew about. And this was found in a renal transplant patient of African origin. And subsequently, this patient loses his kidney in that narrative much later. And BK is the initial of that particular person's name. I think he was of Sudanese origin. And then this interest kind of died till when Dr. Paramjit Randhawa, a man of Indian origin who now works for the University of Pittsburgh, very interesting chap. He described in 1996 human polyoma virus infection in renal allograft, while the previous paper, Dr. Gardner's paper, was mainly in the ureter of that patient's ureteral stenosis. This was reported in histopathology. And subsequently, this hospital could show with immunohistochemistry that renal allografts do get infected and the virus gets embedded in the substance of renal tissue and can provoke an immunological reaction, followed by fibrosis. And so Paramjit Singh Randhawa is actually the person who brought this to our attention. And I remember this paper being reviewed in, by then it was, in Adelaide when I was there. Now, this is a paper subsequently, and rightly, this is all northern India. A paper came out of Dr. Kusum Joshi's laboratory. You can recognize Vivekanand Jha's name there, Dr. Vinay Sakuja. And these people showed that about 9.3 to 10% of allograft biopsies, if stained properly, retrospectively, have BK virus. So it's closer home. Standard immunosuppression that we all use, and there is about 10% BK virus associated nephropathy, BK van, in the Indian population. This paper was published in 2004, quite some time, and after that I haven't found a paper looking specifically at BK virus nephropathy from anywhere else. I would have thought Dr. Swarnalata Gopalan would have something on this. I haven't found any. So immunocompetent people like most of us are not affected by BK virus nephropathy. More than 90% of human population, though, has been exposed to this polyoma virus, either BK or JC polyoma virus, according to seroprevalence studies all around the world. So this is something that you catch probably through air as a child, and we hold it in our urinary system, probably in the tubular epithelium or transitional epithelium, but it doesn't cause much havoc till when there is ischemia followed by immunosuppression. in the main, or with tremendous immunosuppression with bone marrow transplantation. So the virus is not cleared from the human host and it persists. Even though you may have potent neutralizing antibodies and virus-specific T cells, you don't clear it at all. Now, these cells give trouble, not from native kidneys usually, it's usually from transplanted kidneys from somebody else who had with ischemia during transplantation and reperfusion, reactivated this virus. We do shed BK virus periodically in urine. This has been shown in BK positive blood donors, and if you keep following up the urine samples, you would find there are periods when there is viral shedding. So these things tend to go through cycles. I took out the slide on cell dynamics because, oh, it is still there. We won't talk too much about it. It's 3,000-fold higher viral load in urine as compared to blood. And there's a lot more detail that's given, but essentially saying most of the replication happens in the tubular cells. BK virus causes acute tubular interstitial nephropathy, the first two pluses that you can see. And there are a couple of cases where it was associated with MPGN, but no other GN that you can see, while almost all the other viruses have got some pluses around on if you look toward the right side, except maybe human herpes virus 6 and 8. This is a picture of a cryo-electron microscopy. It's not as pretty as cytomegalovirus, and it's not that harmful. Look at the colors, all artificial. It's like lipstick. And you can see that the capsid is not that well formed. Therefore, capsid assembly inhibitors may not work that well, but it does have DNA which can be inhibited. The gene tends to transcribe in both directions, which is rather unusual. Usually, a gene transcription occurs in one direction, while here you can see in the arrows on your left that the gene transcription does occur with early promoter gene and late promoter gene to either side of a circular genome. And this virus has got a funny way of getting into cells. They first get attached to something called caveolin, and once the attachment happens, there is a pinocytosis, and then on, they actually slide down into the cytoplasm and fuses with the endoplasmic reticulum, almost like a child sliding down in the nursery slide. You can see those particles on your right, traveling down the microtubules into the endoplasmic reticulum, and from there, the host DNA enters the nucleus. Not terribly exciting from treatment perspective yet, but I thought it's interesting to see caveolin-mediated attachment and the entry into host cells. So in a healthy person, BKV immunoglobulin is seen in 90%. Renal persistence does occur, but DNA in circulation occurs in less than 1% of cases. And urine does have periodic shedding of BK, which might help in disseminating this virus. And as you can see in the tiny cartoon right below the healthy person, the tubular epithelium gets shed, and that is how the virus gets into urine. While if you have a kidney transplant, like the image on the right side, there is BK anemia, more than 10 to 3 copies per ml sustained viremia, and more than 10 to 4 is when you suspect that the kidney is infected. So it matters with one log fold, the probability of BK-VAN, virus-associated nephropathy, increases. We use that to determine when you want to do a kidney biopsy. If you do too early, you find no BK-VAN, and 3 weeks, 4 weeks later, you got 10 to 4, and your risk of BK-VAN increases. It's not a diffuse process, it's focal, so you need to time the biopsy more or less right. Now, Hans Hirsch is somebody who works in Basel, or Bile as they call it, in Switzerland. He's an Austrian, and he's the father of anything to do with polyomavirus. He classified into 3 very practical classifications: A as mild viral cytopathic change, B as cytopathic change with significant interstitial inflammatory exudates, graded into 3, as you know, and C, less cytopathic changes, but more tubular atrophy, more IFTA, interstitial fibrosis and tubular atrophy. This classification is important for exams. So the podocytes get infected. This is BK nephropathy mechanisms. Podocytes get infected. There is a B cell response, and therefore you can find antibodies. People who have an APOL1 mutation, not Indians, but Africans, for example, Black Americans, they have a high risk of fibrosis and renal injury with the BK virus nephropathy. And then on the epithelial cell of the glomerulus can also get infected around the kidney. Now, if you were to look at these two percentages, sorry, the 1.6 has moved from the next column. BK viremia occurs roughly in about 25% of patients, that is BK reactivation, while BK van occurs in about 1.6 to 2% of patients. You remember Dr. Jha and company have reported 10%. So the truth probably lies somewhere in between. We have to be aware that with sufficient staining, we should be finding more BK virus nephropathy than we are willing to admit. Don't worry about the donor risk factors beyond the first line, that is donor BK serostatus. It matters if you are BK, most of the infections come from the donor. And therefore, if the donor is BK negative, unlikely you will get BK from one's native kidney. It has to be from the transplant kidney. Transplant-associated factors, the most important one is long cold ischemia time. You cool it and transport it around and thaw it, somehow that wakes up this virus, and then it causes relentless replication in the absence of T-cell immunity. And biopsy-proven acute rejection also matters, as does ureteric placement at the time of transplantation. We always associated ureteric stenting with bacterial infection, but remember it also predisposes to BK infection. Recipient risk factor again, if you are naive to BK, you are more likely to be a poor fighter and a poor clearer of the donor BK that's replicating. Rest of it is not terribly important, but HLA mismatch does matter because immunosuppression increases the risk of BK nephropathy. So guidelines for screening, there are two. Every month till either 6 months or 9 months according to two different groups. We tend to do it for 6 months or even longer if graft function for some reason is upset. And people then recommend it every month or every 3 months till about 2 years or 1 year. KDIGO is more conservative. It's only up to 1 year, then annually. That's what we tend to do in Brisbane. There was a question in the beginning on Hoffen. Hoffen is a German term for stacking up things. So if you have these viral casts, you tend to have 6 or more. This is all Hans Hirsch and Nicolette talking about how these stacks are formed. You're required to have a few to form a conglomerate, and that can be seen on electron microscopy. Only Germans would do it. We people popularized Papa Nicolau stain to see these cells, and it's not very reliable, but it's a poor man's way of looking for BK. But don't stop there saying the test pap stain is negative on urine and say there's no BK. You need to do more than that. BK PCR is available, quantitative, if you were to do it. And urine would be very highly sensitive because it's many-fold more excreted, but the correlation with BK van, BK virus-associated nephropathy, is with blood. 10 to 4 correlates with substance infection of the kidney. Now, these are various pictures of how, if you have the right stains, you can see these particles very clearly. And once the tubular cells are infected, they disrupt the tubular epithelium, as you can see. And further on to your left, you can see a fair bit of fibrosis happening. And these are clumps forming already. And on electron microscopy, this is how big a clump can look. But if you have about 6 or 7, you more or less form a Hoffen. And these are stacks, like they show pictures of these being stacked almost discretely, like things in a truck. Here again, you can see SV40 stain, multiple SV40 BK polyoma viral inclusions in tubular cells. Out here, I have put a star mark next to an infected cell and also into a disintegrating cell. Here is fibrosis that's occurring in the context of BK polyoma nephropathy. Once you have a huge amount of fibrosis, it doesn't help to treat it, so to speak, because it's like having a big burn. Treatment causes fibrosis and cicatrization. So you screen, as we discussed, monthly for 6 to 9 months, and then on every 3 months till about 2 years, or at least till 1 year, and then annually, depending on which one you wish to follow and how much of money the patient can afford to spend. And if your viral log count is more than 10 to 4, biopsy is more or less mandated, because that then gives you legal grounding and medical grounding to reduce immunosuppression at least. Now, how do you do that? You need to gradually reduce CNI by 25 to 50% and reduce or stop mycophenolic acid. Now, there's a caveat here. If you stop all immunosuppression, you lose the kidney to rejection. You know that that happens in about 10 to 30% of patients with BKV. And the fibrosis looks exactly, and inflammation looks exactly like rejection. And it's difficult to pry these two apart. So what I tend to do is add my favorite drug, leflunomide, early on, which is an immunosuppressant, and it also inhibits viral DNA by uridine pathway, as I showed you earlier, through dihydroorodehydrase reductase pathway. And once leflunomide level builds up, you have enough immunosuppression, some antiviral property, then it's much easier to reduce mycophenolic acid. And you could reduce it to half if it's a high-risk patient, or you could stop it completely, because leflunomide is a very powerful immunosuppressant. Very powerful immunosuppression, so much so it's used in xenotransplantation. And with that, if BK viremia tends to become less, you know you probably will win. And if this didn't work, you have 2 more agents, IV immunoglobulin and cidofovir. Cidofovir is toxic, so you prefer IV immunoglobulin first, and you already have started leflunomide. That's all what you can do, but there is one more trick up our sleeve, that is cellular therapy. So in this study from Australian data set, what they showed was allograft loss is almost double in people who have BK-VAN. Once the kidney substance is infected, you've got 1.75 times the risk of losing the kidney, but there is no extra risk of mortality in kidney transplants. So in our program, what we do is we monitor drug levels and keep doing BK weekly or every second week. Initially, plenty of BK blood tests are done. We don't do so much of urine. And then if you see a rising trend, you tend to drop immunosuppression. Because we are paid by the Commonwealth, number of tests doesn't matter, so it doesn't truly apply here, but just to show you how it works for us. So if you have a presumptive BK-VAN, that is hematuria, polyoma, viruria, increasing viremia, decreasing GFR, with these 4 you have a presumed diagnosis. Then it's up to you to prove the diagnosis to drop immunosuppression further. With that, if you have that in mind, time is of the essence. Reduce immunosuppression, but at the same time build up leflunomide, and then think of IVIG cidofovir. And we prepare this patient for T-cell treatment. Now, cidofovir, as we talked about earlier in mycophenolate, it is an analog, and but it works only toward latter part of BK virus infection, because the renal tubular cells have to start expressing large T-cell antigen. Only at that stage will this nucleoside analog work. So very early on, deploying cidofovir is not a good idea, and that's not possible in our circumstance. Most people would reduce immunosuppression, start leflunomide, cut mycophenolate, and give it some time. Give IV immunoglobulin. And once you start cidofovir in this regard, you should give it without probenecid, so that the cidofovir gets into the site of activity. You need the drug in the tubule, but the minute you use probenecid, you don't have so much of drug concentrating in the tubule. Nephrotoxicity is a risk, and there is a complication called anterior uveitis. I didn't know about this. I have not seen one, but in a third of patients who get cidofovir, probably hematologists see this or ID physicians would see this. Addition of cidofovir to immunosuppression reduction alone did not change graft loss significantly. So actually we don't have very good treatment for BK virus even now after so many years, almost 25 years since it was reported. Leflunomide we talked about earlier, so I won't go into detail. Essentially 100 milligrams daily for 5 days followed by 40 milligram daily. Check teriflunomide level at 1 month and make sure the level is reasonable, about 40 to 80. Then you can drop mycophenolic acid. So it takes almost a month before this arrangement can be made. Having said that, a prospective randomized study did not show leflunomide to be useful, but I like it because in a high-risk situation, you can reduce the dose of mycophenolate safely. I won't talk about this drug. It's another derivative of leflunomide which was in the market for a short while, and 1 milligram costs $250 US, so I don't think it's going to be particularly in the market. Conversion of immunosuppression, you need to know that converting from tacrolimus to cyclosporin has got some benefit. If you can reduce mycophenolate, there is benefit. You cannot say, people say the best couple is actually potato and onion. So they go together. Similarly, tacrolimus and mycophenolate have been the best couple for transplantation for years together. And BK came around when these two drugs were introduced together. So we are not entirely sure which drug causes more harm. People believe it could be mycophenolate, some people believe it is tacrolimus. More evidence is for mycophenolate, so that will be the first drug to be reduced. Now, T-cell response to viral infection like BK, CMV, TB, some cells which recognize those epitopes of these pathogens will expand. And you need that set of cells if you have to fight when the pathogen is reintroduced. Now, in the setting of immunosuppression, you don't have that expansion, clonal expansion of T cells that are specifically recognizing and are able to target that particular site. So what can you do? You may be able to infuse T cells. Here is a patient who had, one of my patients, we reported, this is the first case in Australia, where we used B-cell specific, BKV specific T-cell therapy. Those cells were generated from this transplant recipient's donor because transplant recipient didn't have any BK specific T-cell. And whatever we did for her, including cidofovir, IV immunoglobulin, leflunomide, the whole lot, none of those worked. And you can see here, can you see the black spots here? These are SV40 fourth biopsy. This tissue is just riddled with BK viruses. We got the daughter's HLA haplotype cells which were fighting BK for some reason, expanded it and infused in about 8 aliquots into the patient, and the wretched virus disappeared. You can see the last one. But unfortunately, the tissue fibrosed. Because any active T cell secretes interferon gamma, platelet-derived growth factors activated, fibrosis predominates the clinical picture. I'll show you the next slide. You finally have a tomb where once there was BK, fully fibrosed, and the battle against BK was won, but the war was lost. Now, talking more about T cells, we should have talked more about it last time during CMV. There was no time. I have 50 seconds. These are cells which could fight multiple pathogens. These cells cannot be created in a plate, but it has to be in people who have education in vivo to various pathogens in small formats. So that is how these cells are made. And there are cells which can fight CMV, EBV, BK, adeno, and Aspergillus. This was created in America, and this clone can be expanded further and further, bottled and sold. In our institution, we have access to CMV, BK, EBV, and adeno currently. These are banked cells whose HLA is known. So if you have a patient who's got a refractory viral infection against all the named viruses, you can specify what is the or very highly defined HLA typing of the recipient, and they'll find cells which are blood group matched and HLA matched, which you can infuse in multiple aliquots, tiny infusions. Every week or so, over about 8 weeks, you have given enough fighter cells into the system to kill these viruses. If it's done early, like I'll show you, it will work. If you do it late, you lose the kidney to fibrosis, even if, like the previous picture, that you kill the viruses, surrounding fibrosis will kill the kidney. Not many reports, but it's getting increasingly popular. There are commercial interests, so everybody does not publish. It is possible to treat that. So T cells is a double-edged sword. On the one hand, it will kill the virus. On the other hand, it will promote fibrosis. Therefore, at some point, we have to increase immunosuppression back, and we don't know what that point is. Hopefully, someday we'll learn how to do that properly. So re-escalation of immunosuppression is important. And lastly, my current patient who's got, you can forget this business of polymer nucleotide amplification assay comment, forget this big column, read these and look at the log fold counts. This is to be read backwards. 10 to 2 in July 22, and July 2023 it's 10 to 3. What happened in between? Then the viral count increased to 10 to 5, and around 10 to 4 we found 10 to 5, early 10 to 5, we found the BK virus nephropathy, got adaptive therapy done after all the cidofovir IV immunoglobulin and everything. Currently, this is only till July, just before I left, he had touched 10 to 2. So very likely, and his function, renal function has improved. You can see here. Take 200 as 2 milligram creatinine. He was around there, must have had BK nephropathy around here. And then with all our ministrations, creatinine went up, and subsequently with IV immunoglobulin, T cell therapy, he is still keeping the kidney, which otherwise would have been lost. What about retransplantation? Allograft survival is fairly good, patient survival is good. So renal retransplantation without nephrouretrectomy is the current recommendation. What are the recent advances? You got a specific human monoclonal antibody which is under trial now, and adoptive immunotherapy, which I am talking about, is on a randomized trial. I think that's all I would currently talk about. There are ways of, with special stains, teasing out rejection from inflammation of BK virus nephropathy. That's also happening at the moment. Thank you.
I have one question. This is particularly about BK and even generally for CMV. After treatment, what is your protocol of restarting antimetabolite if you have stopped it, or you?
It is just by feel. There is no real guideline. We don't want a rejection because 20% of patients reject. I am happy to leave it on leflunomide rather than restart mycophenolate early for whatever little antiviral effect it has got, because we've not had rejection, but another transplant center close to us has had rejection side effects with leflunomide, so they worry more. But we have had lots of experience with leflunomide here, so I am a bit more confident.
So, thank you, sir. It was very interesting. In fact, there was learning point at every level. You have shown the slides. Your slides were very effective. Not only CMV, sir. This diagram was also very good. It was colorful BK virus, and the way you explained, like a child, it gets into the host by sliding. This was very effective. And in fact, we don't routinely get this BK virus nephropathy. As you said, every weekly or monthly you get this testing done. We don't get an in fact, our diagnosis is retrospective. Graft dysfunction, no other cause, do a biopsy, and surprisingly we find it's a BK virus. That's the reason why we don't find much of a BK virus. and we don't monitor blood and the urine BK virus so frequently, sir. And for treatment also, like we had a lot of women, the points to learn, the T-cell therapy, sir. What I'm interested to learn is the T-cell therapy, what you said is, they are taken from multiple hosts, multiple donors, or it's from the recipient?
Single donor,
Single,
HLA specific, so you don't have a problem of the host responding to the infusion and destroying the cells. So it has to be HLA, at least haplo-matched cell infusion.
And do you have to treat the donor, sir? Like, how do you know that this is against CMV?
Common HLAs are marked from all the transplant recipients, and matching donor bloods from Red Cross, which are BK reactive, are collected. And the cell lines are expanded. So you can, with a million cells, you can make 10 million cells with expansion and bottle it into 20 or 40 aliquots. So you have the cells frozen down, and you can thaw it and use it over many years.
Yes, years together, sir. Okay, and is it commercially available, sir?
Biocon was trying to do it. I don't know what happened. We know that CAR cell therapy is there for multiple myeloma, courtesy Dr. Reddy's lab, on trial currently. So this is much easier than CAR cell therapy. So it's only a matter of time. In fact, I was speaking to people with Dr. Reddy's lab the other day, saying, hey, why don't you people have this for us in India? Because it's a need. And there will be certainly people who can afford it. This costs $30,000 in, we pay only 10 because of a trial, but it is $30,000 for the whole treatment in Australia. So that's a lot of money, but I'm sure we can get it for about $5,000. That'll be about 2.5 lakhs. It'll cost money, all right, but it'll be, at least some people will be able to save the kidney. A transplant, a retransplant will cost 5 lakhs. So this will be about 2.5 if you save the day.
And is it likely that the recipient, when the patient, before immunosuppression, the cells are taken, and because, as you said, it can be stored for years together. These are taken against all what you call infections, BK, CMV, REV virus, and stored, and then patient undergoes for transplant. Whenever it's required, he gets the same treated T cells. When is it possible to go that way, sir?
Say that again?
So before transplantation, recipients, but because we know that patient is at risk of all these infections. So before getting immunosuppression, the patient cells, T cells themselves get isolated, they are treated, they are stored, and after years together, whenever it's required, it's taken back, treated to the same patient.
If you have reactive cells, can you store those cells and then use it if you need it? But then you're putting up a lot of money and you may not use it. And any person with disease, DISE, you cannot keep their cells and use it for somebody else. That's a problem. You need a healthy donor to be able to. If I have CKD, I can have my own cells back, but I can't give it to you, even if it's doing certain if it's got antiviral properties, can't give my cells to you. No transfusion agency will allow for that. Having said that, people who already have BK virus nephropathy, kidney lost to that, very likely they will not have T cells that work. Injecting T cells into those people, will those cells educate the recipient's T cells is a moot question. We don't know the answer. The first patient I showed lost the kidney to BK, got daughter cells. Now we have stopped immunosuppression. That kidney fibro, she is on dialysis. She is put up for the second transplant. And we check to see, does she have BK specific T cells? Plenty now. So we don't know where she got those BK specific cells. Are the daughter cells still alive after 3 years? Or have the daughter cells educated the mother's cells to fight BK? Or did mother cells learn on their own? Or were they dendritic cell-like presentation? We don't know.
So thank you. That's a very interesting area to discuss. I think it's go on, and the future is all about cell-based therapies, sir.
Yep, thank you.
Thank you, sir. Very
Thank
interesting.
So we have a few questions from the audience. Graft dysfunction, stricture, etc. are all clinical presentations of BK virus in transplant patients, and they are not in continuum. Why do most people get graft dysfunction while some develop strictures?
It's a very interesting question. What usually happens, they say, there has to be irritation of urothelium, or there has to be ischemia of urothelium for the infection to localize to one area. Some inflammation is required. The same pathogenesis is ischemia reperfusion. Usually there is a lower polar artery, as you know, that feeds the upper part of ureter from the lower branch. If you have been where kidneys are perfused, you would see there's a tiny branch that supplies the ureter. If that is compromised, there is ischemia. So a lot of people believe either a stent or some compromise to blood flow to the upper part of ureter is what causes narrowing at that area and ureteric stenosis. The other area is the site where you stitch. That is at the bladder junction. There again you can have narrowing with BK coming there. That's how the BK man with the first report, that it was ureteral disease.
So are there any interferon gamma release assays similar to CMV for BK virus?
There is. That is done by people who research labs, not commercially available. You can check host interferon gamma release assay for T cell reactivity specifically to conserved BK epitopes. It's available. That is how they can generate T cells for you. But that is, they would not do for anybody else because it's not in clinical application. It's in research application. In order that they can decide whether what sort of T cells should be given to a particular patient. Number of T cells that react to BK are far fewer compared to number of T cells that react to CMV. CMV, there are plenty of T cells, but BK, it's a very small subset.
Thank you, sir.